So my task is to talk to you whether in this pandemic with COVID-19, whether the nuke or interferon going to be the preferred treatment. As we are aware that COVID-19 is still around, and this is the survey from WHO several weeks ago regarding disruptions of hepatitis services around the world. So there are going to be some disruptions of hepatitis service, or that's going to be the problem because of the healthcare system is saturated by the COVID-19 in many countries. Not only for the treatment, but also for the new diagnosis as well as you can see here, that hepatitis B testing is reduced in many countries. However, we have the goal, as WHO has set the goal by 2030 to diagnose more than 90% of the burden and treat those who are eligible for the treatment up to 80% in order to reduce morbidity, mortality by 65% within next year, 10 years. So it's going to be very close. 10 years is not that far. So the goal of the treatment so far is to, as I said before, that to reduce the morbidity, mortality by improving survival, quality of life, and reductions of hepatocellular Nowadays, we have two options, whether interferon, which is now is Peg, and 6 nucleoside analogs, from lamivudine to the latest one is TAF or tenofovir alafenamide. So for the nucleoside analog, this is the direct inhibitions of the viral replication, while interferon has two actions by reductions of the replication of the virus as well as stimulation of the immune system. So it's going to be dual actions. Shown here is the study done several years ago, E-positive by Professor Loud, George Loud, who's here in the panelists, with PEG-2A 180 microgram weekly for 48 weeks. And on your right is in E negative. So at the end of the treatment, 6 months after stop the treatment, in E positive, about a third of the patient can achieve E seroconversion. And also in E negative, about a third of the patient can achieve ALT normalization plus HBV DNA less than 20,000 copies per ml. And a few percentage of the patient can have S antigen loss. Please note that those days in the patient with significant fibrosis, the endpoint was 20,000 copies per ml, which is nowadays 20,000 per ml is not acceptable in the patient with significant fibrosis. However, for the meta-analysis of interferon in the treatment of chronic hepatitis B, it's shown that it can reduce the development of cirrhosis and hepatocellular carcinoma. Even most of the study was small, included in the meta-analysis. So the good candidate for PEG interferon going to be the patient with low baseline DNA, high ALT, and genotype A or B, in the patient with young, without comorbidity, and compensated liver disease. Then, what is the side effect of interferon? As you can see in this slide, this is derived from E-positive study by Professor Lau. So you can see that either interferon alone or in combination with lamivudine, more than half can have flu-like symptoms, especially fever, fatigue, myalgia, as compared with very few percentage in lamivudine groups. Then when we compare with the COVID-19, so you can see that about similar of the presentation of COVID-19 nowadays as compared with the side effect of PEG interferon. Then when we use interferon nowadays, especially in the country where COVID-19 is still prevalent, it's going to be confusing whether it's going to be side effects of interferon or COVID-19. Moreover, during the course of PEG interferon treatment, there could be some flare. Early flare induced by the host, this is good flare, or later, after the treatment, there's going to be bad flare induced by the virus. So this flare can be seen in the patient with COVID-19 as well, up to 50%, as you can see from the recent study by Professor Sarin for the COVID-19 study. The spectrum of the ALT abnormality, even in the patient without cirrhosis, still more than 50%. So during the course of the PEG interferon treatment, the ALT flare going to be another issue that we do not know whether it's going to be by interferon or COVID-19. These side effects make us to monitor the patient more frequently, and this needs in-person visit. So in order to measure the side effect, and sometimes we need to measure the on-treatment response. Overall, interferon is more expensive, but it is finite. About a third achieve viral control, so 2/3 still need another treatment. And during the pandemic era, the interferon in terms of shipment is going to be stored and shipped refrigerated. Now, for the second option, the antiviral agent. So I'm going to focus on entecavir, tenofovir, and TAF, which is more potent and a high genetic barrier. Especially for tenofovir and TAF, this is going to be eligible for both naive and lamivudine failure. And all of these three agents nowadays, they are generic available. So it's going to be very cheap and good for long-term treatment, especially in developing countries. I go back to the originals of PEG treatment in E-negative. This is a study done from Korea regarding the comparison between the patient with complete viral suppression with the patient with low viral suppression but still detectable, whether intermittently or persistently, but still very low. So the incidence of HCC is higher in the patient with either intermittently or persistently detectable HBV DNA. And this is the study from Asian country. This is just examples of study from Asia site where tenofovir seem to be more robust in terms of reductions of HCC, but it's not true in the Western. Maybe when I look at the study in Asia Pacific, whether from Korea, from Hong Kong, this is from Hong Kong, more E-positive subject and higher viral load in our group of the patient as compared with the study from the Western. In terms of tolerability and safety, the nucleoside analog is going to be the most very safe, very minimal side effect, and it can be used in all patient subgroups, whereas PEG interferon is contraindicated in decompensated and in many subgroups of the population. And for the continued treatment of chronic hepatitis B, all guidelines have recommended continue the treatment as well as for those who need the treatment. So we need to initiate the treatment, but we try to limit elective blood donor, in-person visit to the hospital. So in conclusion, it is the clear choice that during this time of COVID-19 pandemic era, high potency nucleoside analog could be the first choice. This could be eligible for the treatment because it is simple, safe. It is eligible for multi-month dispensing and do not require cross monitoring of the side effect. And actually, we should adopt this simplicity amid of the COVID-19 pandemic to achieve HBV eradication within the next 10 years. Even after COVID-19 pandemic era, we should make up our mind to make it more simple for people to follow. Thank you.